sit so I can make sure it's on you. Okay. All right. And I'm gonna minimize that so that you can slide through your slides, okay?
Is there that this thing on here?
No, unfortunately, there's not.
Oh.
I don't know how to do that.
Okay.
Or do you want me? Well, I can figure it out real fast.
Yeah.
You want me to do that?
Yeah.
Okay, let me pull it. Okay, guys, hang on one moment. I'm sorry. Okay. I'm gonna get something else pulled up for you guys on Teams. Actually. Okay. Well, let me pull it up here. Oh gosh.
PCA 98. About 6 months along my surge, 5400. Again, transfer to intermediate carrier ICU. We're 3 to 11. PCA ran back and forth because the only. That was fun. Let's see. I graduated from Blessing in 2000 as a BSN. The first certification I got was because I got bored. So there was a flyer in ICU on the bulletin board that said TNS, prominent specialist. And I thought that was really cool. So about 3 years in, I doing this. I dropped a freshman once a week for 3 months. Charlie Cook, Charlie Paris, PR, and then Aaron, that works for Aaron. The 3 of us Wednesday for 3 months. We take this course. Years later, it's here. So this is the trauma nurse specialist. So if you read it front to back, there's a lot of information in here. If you get a chance to take this course, good. Enjoy it. Every one of these things goes through a different system of injuries going head to toe, and it gives you an early pathway and the pathophysiology to kind of review that area and what it does, and then what kind of injury can happen to it. Most injuries are penetrating trauma, blunt force trauma, and in many other ways. But anyway, this is a good course. Let's see, 2007 was my TCR on the Colts again because I got bored. And then later on, got my master's in science and nursing administration in like 09. And then 2014 or 15, I thought about going maybe trying airvac. So I always thought that sounded awesome to come in, set, and then jump out, save the day, and then fly off. Sounds superhero-like. That sounded cool. So in order to do that, you have to have this one. Pre-hospital trauma life support. So there's different phases, and this kind of opened my eyes. This is for paramedics, and is it like I forget how many week course it is. As an ICU nurse, you can pull this off in 48 hours. I did. That you got to pretend to just blend and pick up a lot. All I got out of the first 10 minutes was scene safe. And then they say yes, and then you carry on. Because if it's not, such as it's a shooting, there's still someone dangerous in the environment, or there's water, or whatever, is the scene safe? Yes or no? If no, drag patient, then get scene safe. Anyway, so this was awesome because this put together what happens in the field. So if you're an ER nurse, you're standing around in your ER bay, call comes in, the phone rings, and they said, hey, we're 10 minutes out. I got unknown. I got a John Doe found in the alley, unresponsive leaning up against a car. What do you know? You don't know mechanisms of injury. You don't know why they're unconscious. You don't know anything. Your pre-hospital crew puts together the pieces at a certain stage. Then they come to the ER. Then you have a trauma team that attacks. Does primary and secondary survey assessment in a very systematic order. And if you trust the system, it takes the energy. And you can calm. And you put a system to it. stay focused, and go head to toe. There's always a distracting injury. The number one rule is don't get distracted by the injury. Someone's going to come in with a big bone sticking out, a femur of something, or a giant knife sticking out of the side of the neck, or this gushing or half a jaw. That's the distractor. You know it's there. What are you going to do about it? But start at the top. And primary survey is where you go. Is anybody familiar with primary survey? Have any guesses? You want to tell me what it is? No. Okay. Mnemonic goes back to ABCs, but this is an extension of it, and it's A, B, C, D, and E. Airway, breathing, circulation, disability, and then extremities, exposure, strip and flip. That's what we used to call it. So that's the primary survey. As you're doing it in that order, what you find, you fix. Because it doesn't matter that the femur's out. You can put a tourniquet on it, but if the breathing, that's good. How well are they breathing? So it's all about an A, B, C, D, E. Then there's secondary survey, which is another head-to-toe assessment that looks more like your specialty assessment that you do every day at 7 a.m. or 7 p.m. And as you're going, and then you also gather ample, which is like used to be called like sample. You're gathering kind of past medical history information. So you're going to put that together too. Secondary survey is where you guys are going to live mostly, but it's being done on a second time. This is the one where you come for my ICU people that work inpatient. You're going to get this one from ER, and then you're going to go your head to toe. But I want you to think secondary survey style, because there may be something that's been missed. Because we have had in the few traumas we had, we find 3 days later a pretty significant surgical necessary elbow, or something as simple as, hey, by the way, that greater toe on the right foot's broke. It's usually the musculoskeletal extremity, something like that that's gotten missed. But it can also be a vertebra somewhere that could also be busted that needs work done too. So knowing the whole thing. So if this is pre-hospital, this is nursing. This is how you get certified. And there's also a TNCC course, trauma nurse course, the 2-day weekend course, right? 2-day course. Some of you have it. Who's got TNS in here? Right. Who's got TNCC? Anyone? Okay. Cool.
Certification, so we'll be able to start offering that. So just send over after that, so many things I'll be able to offer to our critical care staff and PCU staff that want to do it as well. So that would sound pretty cool.
Nice.
Because we can only send so many to TNS, and we can only usually send like 2 ICU. That makes sense. And unless it's completely honest, we'll be able to kind of backfill that TNCC. ICU doesn't have rules and regulations on how to do this. But here at Blessing, we want to have as many knowledge and as much ability as possible.
Yeah. ER has to have one trauma nurse specialist on every shift. So having an ICU, like so, we've been doing this since 2003. I think Claudia was the first one that ever had it. I mean, she barely even remembered. She's just, I think I had that. I think I did that. And that was in 2003. She couldn't remember back. So I thought the foundation for me was a complete review of patho, which was super helpful. And then by the time I was done with this TNS course, I felt like I'd reviewed, I don't know, I just felt so much stronger. Like that really built me from that point on. And then I should have taken CCRN like the next day because it just housed everything. It has multi-system and hemodynamics. On the provider side of this game, the advanced trauma life support is a thing, and then fundamentals of critical care support, FCCS, is another thing. Most places that, as far as like intensivists, when I go on a job search that wants like, hey, I want to be an NP in some other state, some other awesome hospital, they want this within the first year of hire. For me, when I looked around, Research Medical Center had this course. I had signed up for it, but they didn't have enough people, so then they dropped it. I was talking with the residents that were signed up for it. They told me the fail rate was like 50-50. and most people end up in some sort of remedial the next day, and then you work on it and pass. They have skill stations and review. And so when I was looking for material for primary and secondary survey, I have my old trauma lecture from forever that comes off of the TNS. That's going to be loaded somewhere for you guys to see. It's 100 slides long. It's too long. And then I found some other ladies, one out there was a little bit more condensed, was really good too. But then I found, I have these are handouts for you guys. This is out of Advanced Trauma Life Support, which is going to be the best reference for primary and secondary survey. I have this book in the office all the time. This is 8th edition. I have a 9th edition. Now there's a 10th one out. I got this from Dr. Martin in the neighborhood. She ran in the house and brought it out like last summer. She's like, oh, here. It comes with a CD. I think she told me not to use it though. But this is what I want to try to maybe just work from. Am I able to see it on this screen, or should I just turn around?
No. I'm not sure why it can't be on the screen every time I comment.
Okay.
So I'll be your navigator.
Thank you, navigator. So I got this is the outline off the skill station. So we'll go through that. Let's see. Airway maintenance. So we start with A on primary survey, A, B, C, D, and E. Airway maintenance with cervical spine protection. They kind of throw that in there together because you're at the head of the bed, and C-spine is pretty darn important. So the first thing is for airway is it patent? That's, for me, that's mostly, it's ears. What am I listening to? Can I hear it? What's the quality? I can't hear you breathe. I shouldn't be able to hear you breathe. Her airway's patent, but she's breathing. I can listen. I can get in there close, and then you can hear air quality. What's the quality of the sound? Is it going in? Is it coming out? If there's gurgling, is there stridor? Is there a high-pitched sound? Is it tight? Is it not? So listening, and you can assess it. You can look at it. Most everything is look, listen, and feel is really what it comes down to. So this is all this is rapid assessment. When I was looking through this, it says 10 seconds. This is where you're going, airway, breathing, circulation, disability. As a team, from a team approach, they really wanted this knocked out in like 10 seconds. Boom, 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 boom. Which blows my mind. That would never happen. But assessment for patency, rapidly assess airway obstruction, establish a patent airway. So they recommend chin lift or jaw thrust. You guys probably have done that at this point. We got jaw thrust, but you need to know C-spine. A mechanism of injury is something that this book talks about, is high index of suspicion for injury. So that's a whole nother, like there's a lot. Obviously there's months of practice narrowed down into an hour, but you got to be concerned if there's a fall or a car accident or your patient's unresponsive and that C-spine's not been cleared. Lifting that chin back may be trouble, so jaw thrust. Unless you're Pete, I don't know who here was that night, but he did jaw thrust on some old dude that was a DNR, and as soon as he did it, the dude died like right in front of him. So it'd be funnier if Pete was here. It's like, because unless you're Pete, don't you're okay to jaw thrust. Pete did jaw thrust, and the guy went asystole, just like that. He's like, I'm like, what did you do? He says, I lifted his jaw. I said, he died. I said, don't do that. Dead and gone. How did that happen? I don't know. Yeah, stop. Don't let Pete jaw thrust your patient. If you see clear the airway of foreign bodies, you don't know when they ate. Maybe they just left Qdoba and they got in a car accident, and then you've got Mexican all in your mouth. Insert oral pharyngeal airway. Get familiar with the plastic airways. There's a hard plastic curved one. When you put that in, that clears the tongue. That's also a neuro assessment. It really is. If your patient is responsive enough to handle that and doesn't gag, cough, and say, hey, get out of my mouth. Not good, right? You're heading towards intubation if you're doing this. So you put that in, that clears the tongue. And we're only at airway. Get that in. Otherwise, nasal trumpet, if they're a little more awake, these are ways to make the tongue not be an obstruction. Establish a definitive airway, intubation, or surgical cricothyrotomy. I brought something fun. I have with me, it's a magic trick, a 3 mil syringe. The original 3 mil syringe. I have a 14 gauge IV catheter. Your standard 14 gauge IV catheter. take the syringe. I'll need a. This goes right here into the airway, right? And once you're in, this goes on here. Take the plunger out of the syringe, put it on the angiocath after it's in the airway. Off the end of the ET tube, put the plastic tip. Not ideal, but it works. It beats that, or it slows that. Okay. 100% FiO2 is blowing in, and if you can get any pressure to pass, obviously, it's a 14 gauge catheter. You might get 8 breaths per minute. I don't know, but this beats that. So 14 gauge catheter is your friend. Primo, this is just your regular syringe. Cool, right?
Yeah, since John Ford.
Yeah. Switch every 2 minutes. What else can we do with a 14 gauge catheter? Yeah, we're still in airway. But did they get to see that? Okay, cool. Thanks. That'll buy us time for surgical crike. As far as but intubation, they're going to recommend video assisted, of course, which whatever we're most comfortable with at the time. Light scope is super helpful. For one, I could get a camera and I can see what the injury is. Based on mechanism of injury and trauma, if you have facial trauma, I mean, we're going to want anesthesia there. You want a trauma surgeon there. Hopefully this airway has been secured before they ever get to us. But again, some things develop an hour later. Okay. They may go to CT. Some habits lately is they're down there, they go to CT and the trauma wants to come right up. They go, so you're reducing transport, not going to radiology back to, so from ER to radiology, back to ER, then to us, reduce transport, because transport is always considered a risk. There's always a risk in transport for patient deterioration. So a lot of times they're going from trauma to radiology, then to us. And then hopefully that trauma surgeon follows with. When Wilkins was here, that's how he would do it. And then data rolls in as we're getting there, like CT showed fractured pelvis, blah, 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 blah. That was jet installation of the airway. I had to look that up last night. It's a temporary procedure. That's a temporary airway, emergent airway. After that, it's crike, and I'm not that familiar with it, but I know that I'll take a needle and syringe the same, get into the airway. You have a little saline in your syringe, so that if I'm in the airway, I'll get bubbles. Take the syringe off, and after that, it's like putting in a central line. You add the wire goes down, needle comes off the wire, make your incision, and then follow the wire down with whatever device that goes into the airway. So airway, got to have an airway. Yes, we have a giant bone sticking out of the femur, right? You can turn the catheter off, airway. He'll die hemorrhagic or he'll die hypoxic. You have to fix as you go. This is the quick A, B, C, D, E. So breathing is ventilation and oxygenation. Rate, depth, and quality was what was drilled into my head in TNS. Breathing, yes, I'm breathing, good. But what's the rate? Is it 6? Is it 60? What's the depth of the breath? Is it shallow? Is it big neuro breaths? Is it crescendo, decrescendo? And what's the quality of that thing? Are they splinting? If they got 8 ribs broke on one side, 3 on the other, are they splinting it? But expose the neck and the chest and ensure immobilization of the neck, right? And determine the rate and depth of respirations, inspect, palpate. So we've really got to get back into the mode of getting your hands on the patient. So you're looking at the neck, you're palpating the neck. I'm looking for subacute emphysema. Is the trachea midline? And I'm feeling down. Do I feel crepitus? This is where you find broken clavicle. This is where you find a big old hematoma, a laceration, a giant bruise. And if you have to think anatomy, what's underneath what I'm seeing? You're looking at a person, but you've got to start thinking it's a container full of parts. What's under this neck? Because zonal neck injuries have all kinds of stuff. This muscle under here, you've seen me when we put in lines. I've got IJs, I've got carotids. You could smash hard enough to bruise these things, but not show anything. An hour later, you show the large bruise there, or I have obvious, so there's blunt trauma or there's penetrating trauma. If you've hit something hard enough to fracture the clavicle, what sits under here? I mean, you got subclavian, you have vessel injuries, you've got airway, you got the top of the lungs. So if you can force break a bone, you can break soft tissue underneath. Yeah. Whiplash. You have rapid deceleration injuries. So when they talk about car accidents, whether it's frontal, side impact, rear impact, or rollover, or ejection. Ejection throws everything out. It's just a circus of possibilities. Frontal impact, you have rapid deceleration of the vehicle, right? From highway speeds or 30. It's important to know certain things about an MVA. We could do a whole class just on car accidents. But rapid deceleration, also falling is rapid deceleration. It's certain flights are survivable and some aren't. And that really depends on what you land on, whether you're a kid or whether you're an adult. Anyway, but that's the same thing, rapid deceleration force. The body hits an immovable object and comes to a stop. All the parts inside the body continue to move and then come to a stop. So you have rapid deceleration of the vehicle, rapid deceleration of the occupants in the vehicle, and everything inside the body as well. So you get, when we talk about that, you have, when those things stop, everything has a ligamentum or some sort of connecting tissue that holds things, they're attachments. Organs have things of attachment. The aorta is on the back of the heart. The heart comes forward. You can get tearing at certain parts of where the aorta attaches to the back of the heart. So everything inside the body comes to a rapid deceleration as well, and there's shearing forces. Brain has shearing forces from rapid deceleration. You get diffuse axonal injury. All right. Anyway, I get off on a tangent because trauma is fun. Yes, immobilize the neck, determine rate and depth of respirations, inspect, palpate. So you're going to look, you're going to get in there and feel. Tracheal deviation, unilateral and bilateral chest muscles. I'll sometimes put my hands on there, and if you can feel one side moving more, or your asymmetrical breathing, you're thinking flailed chest, fractured ribs, cracked sternum, chest trauma, right? Is there something going on? And you're looking, bruise, injury, seatbelt sign. What if sometimes you get bruising across here and across the pelvis, or abrasion, because it's rapid stop. And you can tell if they're wearing seatbelt, is it passenger versus driver, airbag deployment, is there a windshield that's been starred? There's two kinds of ways you can travel, up and over or down and under, and there's different injuries based on that. If they stomped on the pedal and they slid under, you get hip dislocations, fractured hips, fractured pelvis, lower extremity fractures. If you go up and over, you got the chest, they call it the ring of injuries where the steering wheel sits. And if you hit head, or if you star the windshield, or if you hit the cross brace, all these things happen if you think about mechanism of injury. Percuss the chest. Most people don't do this much anymore, but you're going to obviously, it should be hollow. You should hear air. It should be a versus. If it's dull, there's probably blood. So you've got something that's filled a space that shouldn't be there. So you hear sound change. And then auscultate. Don't hear breath sounds. How many pneumos we have this winter and everybody's trachea was in midline? No, I've not seen one shift yet, but it's still there. I guess these things happen. And everybody says, I got breath sounds both sides. Everybody has breath sounds both sides. And then I get an x-ray and I have a giant ass pneumo. I don't know what to tell you. X-ray is still my friend. In these things, though, in the trauma bay, if they don't have breath sounds on one side or the other, they don't screw around. When I did FCCS and I broke into a case scenario group within the trauma, and the trauma surgeon was running this little skill station of like 8 of us, and we're all introducing ourselves. And I'm like, well, I'm a nurse practitioner. I passed boards Wednesday. That was fun. He's like, oh, good. So right away, I was super smart with my answer. He's like, what do you hear? If you got no breath sounds, what are you gonna do? I'm like, oh, needle decompression, second, third, mid-clavicular, second, third, mid-clavicular, blah, 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 needle decompression, blah, blah, blah. He said, no. Like, really? He's like, no. What else? You're in the trauma bay. Why not? He says, yeah, just chest tubes, man. And he says, I'm putting chest tubes in. We don't horse around. And they even talked about this finger, if you had to. Poke, bilateral pokes, fingers, open that up, get it out. They will die if you don't. And it talked about CPR is almost useless. You're not going to have cardiac squeeze. He's like, don't start CPR if you've got hemo-pneumo on both sides. That heart is not going to fill with blood. You're in cardiac shock. Cardiac output is nothing, and there's no filling, and there's no squeezing. So there's no sense of doing compressions on that heart. Nothing's going to pump out. Put 2 big holes on both sides, get that out, get the pressure out, and then stick chest tubes in it. It's not nice and clean and cute little incision. It's all pretty. Just and then start CPR if you have to, and resuscitation with fluids and blood, lots of blood. Management. So high concentration oxygen, ventilate, bag mask if you have to, alleviate tension pneumo. Here's your 14 gauge. This is mid-axillary, and we're going in. And hopefully we'll get a rest of air. Hold the needle out, hopefully I'll get a rush air. We have found in reality, now that we've done this a few times, deeper, probably, and it's interesting, positions everything. You've got me through the rib, but sometimes you have to angle that around, just right to really get. And it's like you just start the shit out of it, put 8 or 9 of these things in there. It's not that effective, but it's what's recommended, and you should do that until you get something else. We now have the Thor event, which is pretty darn awesome. That thing I wish we'd had all of our career. 11 French, about a 5-inch needle, if you will. It's a trocar needle, and it's got a catheter over it, and go in and find the same location. Depending on which side it's on, and chlor prep it quick, and take the scalpel. We've learned to make the hole because I try to be nice and it won't go in. So make the hole. Then you put that right in your scalpel hole and push until you feel it pop through that pleural, and then slide that catheter in. And if it won't go good, you might go a little deeper, and then it will go in. Push it all the way in, pull out. Now it's a flutter valve that's inside that. So when they breathe, it should come off. It comes with a syringe. You put on the top of it, open that up. You can actively pull air off 60 mils, and it'll whistle 1 pitch, and then it's a one-way valve. So if you push on the other side, it's a high pitch on the other side. So, and it won't push air back into the chest. It only pulls off and pushes out. You don't have to turn anything. And that's what it's going to keep sounding like. You need to just keep doing this until it gets where you've got some restriction to get a chest x-ray, and that thing's already done. And it's pretty fast. You can hook it to suction right away too, to the wall, and that'll fill. We found that we're hooking it to the box helps set it at 20 cms because the box atrium, the chest tube box, has its auto regulation of governor of 20 cms of water. And you can run that to your regulator. Your regulator, you could honestly turn it up to 80 and be in trouble, of course, if you just hook it straight to the regulator. So right off the box and into the regulator, and then get it off. We've also gotten fluid out of that too. It's not recommended grade for that, but I've gotten 600 or so off of that thing on a hydro pneumo that had fluid on it. So, but if we're in this situation, I'd go with that till you get the Thor event and put it in. But because you can get a pneumo later. We could have something small, but the patient got vented, had bad airway, got intubated, went to surgery, life's good. They come back to ICU, transport. That's why we get the chest x-ray and then ICU after OR or any new ventilation issues, right? or changes on the vent of tidal volume of inspiratory versus expiratory. Am I getting my volumes back? Where are they going? I get an x-ray. So being on the vent for a while could aggravate a small pneumo or a missed pneumo, and now the lung went ahead and said, I give up, and collapsed. And then if we had an ER, if you have this big old, hopefully you don't get a sucking chest wound that got missed. But if you did, we need to close it and turn it into a tension pneumo, and then we need to do something different about that. This is surgery. You should have a trauma surgeon there, just to OR, things like that. Attach a carbon dioxide monitor, CO2 monitoring. This is why we ask for that for almost everybody now. Trauma already. This is in primary survey. They've already recommended it, which is interesting. Attach pulse oximetry, so CO2 and PO2. Next is C, circulation with hemorrhage. Hemorrhage control. So that's kind of, you've got a good airway, you've assessed it. You have a patent airway, or you didn't, you did something about it. Moving on, breathing. Rate, depth, and quality, it was fine. Or it wasn't. You found a pneumo, tension pneumo, you fixed it. You put in a chest tube, you're ventilating, you're oxygenating, patent airway, and you're ventilating. Now you're moving to circulation, because you gotta have A, B, and C. And you've got C-spine control. Circulation with hemorrhage, you're now there. Identify source of external exsanguinating hemorrhage. This is the way you're going to die first, right? They've already got classifications of shock, of hemorrhagic shock. There's class 1, class 2, class 3, class 4. How much volume can you lose? And they've done enough science that you can know how much volume is lost in certain injuries. In that abdomen and retroperitoneal, you can lose all your volume. You can bleed until your body is empty and you have tamponaded. The abdomen is full of blood, and whatever's left in your circulation is your blood pressure. I've been there. I've seen that with the 2-year-old that we had. Bled everything into his belly and then gave 2 units of blood, liter of fluid, volume, and that's what the kid's blood pressure was left at. So, which is super scary if you're in the OR, because you're going to empty that off, and then you better find that bleed now and clamp it. So these are surgical interventions, but hemorrhage control, find it, put a tourniquet on it. Hopefully pre-hospital has already done that. Identify, otherwise you're holding pressure. Identify potential sources of internal hemorrhage. There's a whole nother class on what kind of signs and symptoms of chest, abdomen, and bruising, of different cool signs, right? Different signs. If I got left shoulder pain, tells me I've got something down here. If I've got a bruising around the umbilicus, that colon sign, C-U-L-L-E-N-S, there's umbilical bruising, something's underneath, peritoneal. So there's a whole cool world of signs. You're like, oh, it's like, you know, all the secrets to the universe. So you're looking for this: belly pain, distension, not distended, soft, hard, flail chest, things not moving equally. We talked about this, I talked about it with Christine, we were talking about it. When you feel pulses, when you're palpating, yes, I have a pulse. No, I don't have a pulse. I have a pulse, but what is its quality? Is it thready? Is it bounding? Is it weak? Is it intermittent? Does it come and go? Is it positional? Is it the same on both sides? Your pulse could be a systemic issue, or it could be localized issue. This arm's trashed. It's been destroyed. And is this a peripheral issue of circulation at that location? You could have a good brachial pulse, but crappy peripheral. Or this is trashed up here, and I don't have brachial, I don't have this. So I have some sort of vessel impingement, right? Can you move your thumb? And so I have nerve and vessel impingement. It's not a systemic shock issue. It says quality, rate, regularity, and paradox. Skin color, right? We get pretty good at, are they pink, warm, dry? Is this pale? Are they pale all over? Is it systemic or is it localized? That arm is different color than the rest of the body. Measure blood pressure if time permits. That's interesting, right? This is what I'm saying. When you guys take blood pressure and you're like, hey, I got this, but I'm like, did you feel, when you do your assessment at the beginning of your shift, do the pulses. I always takes the anxiety out of me. I know what that pulse feels like on both sides. When I go to a rapid, I check pulses, and I know, is it weak, is it thready, is it bounding? But at the beginning of your shift, that's your baseline. 4 hours later, it's midnight, and you're like, hey, my blood pressure cycled a couple times. Did you check pulses? Well, he's breathing. Did you check pulses? Go in and check the pulse. Does it feel like it did at 7? Okay. Then you go and check, and you're like, it does. And so then your cuff's crap. I don't know. But we got the same, you got good pulse on both sides. It feels just like it did at 7 o'clock. So we'll troubleshoot your blood pressure cuff, find out your patient's probably just fine. So yeah, if you have time, get a blood pressure. But in a secondary survey, you're definitely going to have your vitals. Management now. Apply direct pressure to external bleeding. That's kind of obvious. Somebody's going to hold pressure. Somebody's going to get a tourniquet. Consider presence of internal hemorrhage. You have to look, are you bleeding outside? Are you bleeding inside? It's going somewhere. So you can have hemorrhagic shock with no blood loss externally, but you got to be looking for where it might be, which is why mechanism injury to be thinking about. What if you got hit by a car, you can think about how the height of the bumper and the height of the person. And there's a whole triad for that. I don't know if it's, I forget. It's what else triad? There's another triad. Huh? Yeah. And people, if the vehicle braked, the bumper drops. You get busted femurs, you can get busted knees. Depends on the height of the vehicle too, or the again if it's a kid or it's an adult. And the impacts here, hood, ground, right? Or adults can tend to lateral, so then you get unilateral injuries. So that's where you may have asymmetrical chest rise and fall, pelvis fracture on the right, those kinds of things. Insert 2 large IV catheters. Yes. One's not enough. Get another, or another, or another. Yeah. If they come up with one, get a second one. When they come to your floor, make sure both your IVs are good. Because if you lose them, you're in deep shit. Or did your trauma surgeon put in a line? Or did I? Initiate IV fluids. Obtain blood for hemologic. So we're gonna get ABG complete. It's pretty user friendly. This basically says that it's H&H, it's electrolytes, it's a pregnancy test if appropriate, type and cross, and ABGs. So an ABG complete with a type and cross is kind of your friend. They have a trauma panel labs that you can order. Initiate IV fluid with warmed crystalloid solution and blood replacement. Prevent hypothermia. Hypothermia in trauma is a big thing. It's always forgotten for most of us that don't know what we're doing, but if you know what you're doing, hypothermia is important. You got to keep them same temperature. They're already exposed either by the weather or in your trauma bay. And it's refrigerated saline, refrigerated LR, refrigerated blood, and you're lowering them. Trauma doesn't like that. Coagulopathies get screwed up, DIC, things. Anyway, keep them warm. Gotta stay warm. Disability, this is going to be neurologic assessment. This isn't what you think it is. This is not a complete neurologic assessment. They used to have, what is it, AVPU? Does that sound right? They used to have that. This doesn't mention that, but determine level of consciousness using the Glasgow Coma Scale. This is quick. Do your GCS. It still talks about less than 8 intubate. If it rhymes, it's true. I've always fall back on that. But you do a quick, you're trying to decide whether this guy needs to, if you're not. And are they able to, I think most of their studies have shown over the years that if you have that low of a GCS, you're not able, the risk of protecting your own airway is not good. Which means if you put them on BiPAP, that sounds great, but they can't protect their airway. So if they vomit, they die. So BiPAP's awesome if they can participate. Assess pupils for size, big, blown, or small. This helps you for many things, right? Mydriasis, meiosis. Why? So there's certain toxidromes, such as like narcotics or anticholinergics, or I have swelling, unilateral, or mass effect on the brain. So traumatic brain injury is going to be your kicker for that. What pinpoint pupils, or I have blown on one side, and one side's bigger than the other. Equality. Are they equal, and reaction? Do they react to light? So I have optic nerve injury. What do I have? Because you have shearing forces, or you have head injury forces, and it can be lateral, rear impact, exposure. Back on circulation, on the secondary survey, I think it talks about it there, but in case we're out of time, you can have hypotension, and it might not be hemorrhagic. So what kind of shock will give you hypotension, but not volume loss? and not sepsis. Yeah, and what's another system? So spinal cord injury. So neurogenic shock. You can have spinal cord injury on the scene, spinal cord, and you're in shock, and you can have spinal cord injury that's creating a neurogenic shock. Usually with that, it says bradycardia and hypotension together. The tachycardic response isn't normally whenever you learn about neurogenic shock, that there's not a tachycardic response. Doesn't mean they're isolated either. You can be bleeding to death and have a spinal cord injury at the same time. One doesn't rule out the other. So that'll screw up your symptoms. You're like, oh, you're just dealing with a circus. Exposure, environmental control, completely undress the patient, but prevent hypothermia. Kind of hard to do. It did mention in here, patient's warmth overpasses your interest in how you feel in the room. Sorry, sweat to death. I don't care. They don't care, which is difficult. Adjuncts to primary survey and resuscitation. These are the things you're going to do. That's not you. What's another tool? You're the first tool. After that, not to call you all tools. ABGs and ventilator rate. Monitor patient's carbon dioxide, end-tidal CO2, ABGs, EKG. So insert urinary catheter and gastric catheters unless contraindicated, and monitor the patient's urine output. That's an assessment piece, right? Huh? Yeah. So you put in a urinary catheter, male or female, you put it in. What are you thinking? You need to pay attention to what you get back. If there's hematuria, and this is a trauma patient, why do I have blood in the catheter? So seatbelt comes across, retroperitoneal bleed, the bladder sits here, the pelvis sits here. Sometimes there's a communication. You could have a ruptured bladder. We pull the catheter and go through the bladder and into a retroperitoneal space. You could have the urethra could be torn. Somewhere in this tract, there's damage. Kidney, side impact. I turned, the bumper hit me. Whatever, any blunt force trauma. It didn't show you because it's not penetrating trauma and you didn't find the laceration or the stab wound or whatever. This guy got stuck 7 times, right? We're like, oh my gosh, that eye. Oh my gosh, I missed the stab in the flank. But you saw blood in the urinary catheter, and you're like, where's that coming from? So you check out the perineum, you looked at the abdomen, you're looking him over. Hey, let's flip him again. Let's go back to this primary, secondary survey. I know ER did this already. Oh, there's a hole. Crap. And that's the thing you missed. There's all throughout this course, they always throw up some sort of cool thing. Some distracting injury that we're all excited about and we fixed, but the guy coded, he died. And after the code, they flipped him over and they find him. He's still got a knife in his butt. There's something. So high index of suspicion. Got to look at everything. Systematic, head to toe. Basins, bilateral breast, insert urinary catheters. Gastric catheters, you put down an NG tube, you get blood back. And it's in the gastric, think injury, trauma. Got to keep thinking. So if you see blood where it's not supposed to be, something's wrong. We have to chase that rabbit, chase the next rabbit. And while you're down there, you need to be assessing what you're seeing, because you can. I know there's another sign, but again, you're looking for if there's flank pain that comes around. Seeing there, you got to be thinking about retroperitoneal bruising in the groin, scrotum, taint, all that area. What are you seeing? Sphincter tone is another one. You're thinking spinal cord injury. Do I have sphincter tone? Is there blood in the rectum? That's all. Some of that comes in secondary survey, though. Pelvic x-rays, AP and chest and pelvic x-rays, another adjunct. So ABGs, end-tidal, pulse ox, EKG, x-rays. And then consider the need for fast exam or DPL. I have not seen DPL done in a long time, but the ultrasound is becoming so useful and available and at bedside. The ERs guys are going to be right there with fast exam. So I've got an ultrasound book in the office if you want to come see me. And I've got some handouts on that too that I can get you on how the fast exam is done, but it's a rapid trauma assessment for possible sources of check. I check this space, I check this space, I check this space, it's like 9 ways to die from internal bleeding that can be caught on ultrasound. And if you're there, you get good at it, and they've got to find those things. DPL was the old way, diagnostic peritoneal lavage. You got a needle and a syringe. Draw off. Should not get blood. You get blood, but I'm not going to do it. I don't know what I'm going to get. I don't know. I don't want to do that. If you're, yeah, you need to just go to surgery. Secondary survey and management. So now we're finally to secondary. So as a team, if you got through primary, that needs to be, I've spent 30 minutes, 20 minutes talking about that. Secondary survey assessment, ample history and mechanisms of injury. Ample, is that going to be on here? It better be. Here's just allergies, medications, past illness, past pregnancy or current pregnancy, last meal, this and last menstruation, and E, events, environment related to the injury. That was your preamble. So you're trying to get some back history. So obtain the history from the patient, family, or pre-hospital personnel. Maybe EMS is all you got to go with. After that, we medical record sharing. I got to do some digging and try and chase down other hospitals. Obtain history of injury. This is the mechanism of injury. What happened? How did it happen? What was the environment that it happened in? If it's what speed? There's so that's a whole nother world. If it was a car accident or a stabbing or a shooting or electrocution or a roofer fell off the roof, all that. After that, it goes back to head, cervical, chest, abdomen. We're doing head to toe secondary survey. Head and maxillofacial assessment. Everything really comes down to inspect, look, feel, listen. So inspect, palpate, percuss, auscultate. So and inspect and palpate the entire head, face, and you just go head to toe. Get your hands on the patient. Lacerations, contusions, cuts are going to be obvious. Contusions may not be right away. Fractures, you want to feel if things feel loose and or bony or crepitous or crunchy. Thermal injury too, something could be hot or burnt. I mean, you could have a fire in a car. You could have electrical. You could have grabbed a wire on the roof and got lit up and then hit the ground. We've seen it all. Reevaluate pupils again. This is your reassessment. Here's what you had a bleed, but it was small, and now it's bigger in the head, and now your pupils are different. It wasn't earlier, but it is now. That's new. Reevaluate level of consciousness and GCS score again, because it can deteriorate. Assess eyes for hemorrhage, penetrating injury, visual acuity, dislocation of lens, presence of contact lenses, because you can have all these injuries, but you could also have, that dude got stabbed 7 times, but the right globe was trash, right? But if you didn't look, you didn't look. Evaluate cranial nerve function. Inspect ears, nose, cerebral spinal fluid. We used to, I mean, obviously you can get in there and look. We can get under the nose, we can get in the ear, we can look at all these things. And they also had the halo test. Anybody heard of that? I don't know if we still do that. We've done it in the past, and this got a 2x2 or a 4x4 and get it wet. And then CSF stays in the middle, and the blood goes to the outside, and it kind of creates a red halo. I've seen it. We've used it. It's been successful. But also, I mean, you guys like trauma, so you're here. I have seen memories sitting on the upper lip. This is nasty. White brain matter look to us like cottage cheese and baby oil. Gross, right? Hope you had breakfast. And we have sat there. The dude's on the vent, sitting in room 4 like this. And on that upper lip and a yonker, and we're just sucking math and science and 4th grade history right out of that nose. It's just right here. I'm like, oh my God, there went another memory. It's, oh, jeez. It was, if you've never seen brain matter coming out the nose, I don't encourage it. No, I don't go look for that. But if it happens, it's pretty damn impressive. I'm like, oh my God, is that really what we're doing? Like, yeah, that's disgusting. Oh, wow. Yeah, he's doing great today. Yeah, he died. Evaluate cranial nerve function. Look for brain matter at the nose and ears now. But cerebral spinal fluid is a big deal. If you got communication of sinus and CSF infection, right? There needs to be a blood-brain barrier. if that's open communication, that's usually inside. The hiding one is the orbital wall blowout fractures. So you don't want to be able to communicate sinus and CSF. Antibiotic. As a provider, I got to remember to put on antibiotic for that kind of crap. Inspect mouth for evidence of bleeding, cerebrospinal fluid, soft tissue lacerations, loose teeth. All depends on mechanism of injury. Lefort's fractures. Anybody heard of Lefort? His French. First of all, don't trust the French. Don't trust the French. Mr. Lefort, yeah, he would climb. Instead of took a dead body and put it here, climb up on the ladder, and drops bowling balls on people's faces. A lot. New face. Bring me another body. Bring me another body. Peeled everybody's face back. I said, you can't just check bones without peeling faces back. So then he pulls off faces and checks bone fractures. He found that was eight? Is it 8? Anybody remember? Anyway, there's all these different Lefort style fractures, named it after himself. If the face is fractured, it fractures in these different ways. So if you see this fracture, so imagine if you get good at facial fractures and structure and that kind of stuff, and you're a guy that puts these things back together for a living, you're going to be able to tell this a Lefort's 1, a Lefort's 2, a Lefort's 3, Lefort's 4, different ways, and things are loose. And it's a neat thing to study because it's going to cover it in facial trauma. When they put these back together, years ago, I had to see Dr. Riggs do a facial reconstructive surgery and peel something back. It looks like a what do they call that? Electroset. We had a set as a kid that had little pieces, strips of metal, that had little holes, screws, and you could put all kinds of things together. And you just screw, and you just put all the bones, put it back together. But we also have plastics now. We don't have much, but we got a plastics guy. When considering transfer, it's interesting. Sometimes you got to figure out which injury gets to stay. Some injuries got to be shipped. Some injuries don't have to be shipped. And sometimes you got to fix an injury and then ship. So like if you have a hand massive, we had a guy one time that was working on a car. His belly got caught in the fan motor and his hand got trashed. We don't have plastics. He needs plastics. But is this gut stable enough of an injury that he could transfer to Springfield to get the gut repaired and the hand, or we need to go get the gut repaired now and at the sacrifice of 2 to 3 hours of a right hand? What if you get into this massive belly surgery that's much bigger than it is? So a good assessment. I think we ended up transferring the guy. The belly was stable enough, transferred so that he could get both repaired, because you need to have a right hand in life as much as possible. Anyway, interesting. You had to make some choices. Percuss as well. So entire chest wall assessment, blunt injury, penetrating trauma, subcutaneous. So this is all, is it symmetrical? Is it not? What do you feel? And then hyperresonance and dullness again. Management, once again, is secondary, is needle. If you find something in your secondary assessment, you're back to needle decompression, chest tubes, open in the chest wounds, put a dressing over an open chest wound. Pericardiocendesis might be here. There's a whole little triad sign for that too. What was that? We talked about that. You know this. For cardiac tamponade, what's it called? Beck's triad. What is it? Muffled heart tones? Yeah. If you get that 3 on Beck's triad, don't call Beck. Call me. We're going to call cardiothoracic surgeon. And then, there you go. And there's a 4th one, which is hard to figure out. It's like, pulse, this one's higher, that one's there. What? Can you explain it? Okay. Yeah. So then we have fluid in the pericardial sac that's restricting the full expansion and filling of the heart. So you have reduced filling, reduced cardiac output, hypotension, shock. So you have hemorrhagic shock that turned into cardiogenic shock. You have a pump problem. So it needs to be fixed. Abdomen, inspect the anterior, posterior abdomen. Look for signs of blunt trauma and penetrating trauma. Am I bleeding out? Am I bleeding in? Auscultate for bowel sounds. Do I have them? Do I don't? Percuss the abdomen. Dullness, firmness. What am I hearing? There's a nice, on this form, there's a whole graph that you can look at that does the whole secondary trauma. What you're looking for, what to assess, what are your findings, and what do you do about it? is nice. Okay, I suggest check that out. You're not going to get a better reference than advanced trauma life support for trauma. Palpate the abdomen. So you're going to look, listen, feel. That's the main thing. Pelvic X-ray. Pelvic fractures are a big stick and deal. I think we have to, right now, I think our current status in orthos, we ship. Sorry. I think pelvic ship. Problem is with pelvic, if you have enough force to fracture big bone, then you have soft tissue injury, you have vessel injury, because femurs and pelvis, those kinds of things take a lot of force to break. And if you can break that, you can bust a lot of things in that area. So you can lose you can bleed to death inside a pelvic fracture. They have we have a pelvic girdle that you should be aware of that they can put on. CT of the abdomen, pelvic X-rays, abdominal ultrasounds. Transfer to the operating room, wrap a sheet around the pelvis or apply a binder, whatever we use here, which is a binder now. Reduce pelvic volume and control hemorrhage of a pelvic fracture. Peritoneum, rectum, and vagina. Assess for contusions, hematomas, lacerations, urethral bleeding. So we're working your way down head to toe. These are the areas that might not get checked. It's secondary survey. And you're like, oh my gosh, did you see this? Because there could be a straddle injury. Yeah, they fell, but nobody realized they fell onto a fence or where you're riding in the car. So there can be trauma. And you may not know if it was a witness trauma, you got a lot of information. If it's unwitnessed trauma, you just don't. So you have to have a lot of suspicion. Rectal assessment, rectal blood, sphincter tone, that's neuro, bowel wall integrity, bony fragments, shouldn't find that, and prostate position. I have no idea where that prostate. I have not assessed enough rectums to know where the prostate belongs. And I'm not going to start tonight. Vaginal assessment in selected patients. Selected, I would assume you have to have a vagina. Presence of blood in the vaginal vault and vaginal lacerations. You check everywhere for blood, right? Musculoskeletal is a lot, but what they told us in a nutshell, PMS, pulse, motor, and sensation in extremities, and get your hands on it. So you want to assess the arms and the legs real fast. Do I have a pulse? Yes. Radial, ulnar, both sides. Do I have motor? Can you do this? Can you do this? Can you do this? And then repeat the same thing on the other side. You only have to know one because you got to do it on the other side. Same thing on the leg. You need to do femoral all the way down. Do you have all that circulation all the way down? Because if that's the side with the injury, you need to be looking all the way down. And can they move it? And then look for any disability in that use. I'm unresponsive. So now you're doing passive range of motion, but you need to, and you're feeling down the arm for crepitus, because what you feel, you need to be looking for deformity and range of motion. Radial nerve injury, ulnar injury, medial injury. So you could have nerve injury at any point in this, but if they can give you a thumbs up or an okay sign, or they can adduct and abduct fingers, this is radial, medial, and ulnar nerve assessment. And pulse, So have you just done neurovascular? And can they feel? So pulse, motor, and sensation. Can you feel this? Can you feel this? Can you feel this? Can you feel this? That pretty much will get you what you want out of a musculoskeletal as far as extremities. That is going to be how you're going to catch the busted elbow in your vented patient on sedation. Catching the greater toe, that'll be difficult. Zwick's last trauma out of all the injuries, he's like, oh, and by the way, the greater toe on the right foot is broke. Good job. That's what I straight up told him. I'm impressed. You got all that, and you still checked the toe at the bottom. Doesn't do anything, but it's a good find. Pelvic X-ray is always important. We talked about that. Management, apply or readjust. We're not going to do a lot of splinting. We're going to get ortho. That's the main thing for us. Tetanus shot. Got to have it. Got to give it. Every trauma patient gets a tetanus shot because you're wondering why it's on your medical record, on your EMR. And they're like, so you need to know when you get a report from ER, did you give the tetanus shot? Huh? Okay. Got to give it. Compartment syndrome. That's going to be the one. I don't think we're going to probably see that in ER. That's an ICU finding. Yeah. Is it? So it's swollen. Is it is this fascia under pressure? Do you have that much pressure in an extremity? And it could be anywhere. But ones we normally see is busted leg, broken legs, broken arms. But for us, it's really been legs. We had a horrible trauma about the first year I was here, right? That first summer. She's passed away, but Carissa Summers, right? Was she the one? She had fascia, both legs. We had to do fasciotomy. Out of everything, the hemorrhagic shock, DIC, everything we got her through, and she still, then it was compartment syndromes of the lower extremities. And so obviously tissue under compression is not getting tissue perfusion. And that is going to end up with death, right? Muscle death, tissue death, vascular flow, nerve damage. So nerve and vascular and tissue death. And if tissue dies, it gives off toxins, will contribute worse to the DIC and shock. Fasciotomy and release the pressure. And you're already bleeding, so it's even greater blood loss because if you're in some sort of coagulopathy. You give that's a whole nother lecture of sanguination and lots of blood products, how to mass transfuse and set negative outcomes out of mass transfusion as far as DIC and clotting factors. But I always, if we get a trauma patient and you're worried about it, make sure I haven't overlooked it but I'm usually pretty quick on checking a fibrinogen and look for a DIC type panel. Because it's like that's the secondary thing that happens out of sepsis and shock and trauma. Sorry for running over. We're on neuro, reevaluate pupils and level of consciousness and GCS again. Now you're gonna get more of a full-headed neuro assessment on this one. Upper and lower extremities, motor and sensation. We just talked about that. Looking for lateralization. I got something on this side, but I don't have it on this side. Spinal cord injuries is a whole nother discussion too, but whether it's central cord, anterior cord, or Brown-Séquard syndrome, whether based on where the cord injury is, okay, and at what level. So dermatomes is a whole nother conversation on what level of the injury and how it will present. Adjuncts to secondary survey. So in the primary, it was ABGs, H&H, BMP, X-ray, end tidal CO2, and pulse ox. Adjuncts to secondary, spinal X-rays, CTs. This is where you're going to go for CT, head, chest, abdomen, pelvis. If you haven't done a thorough assessment, you waste your trip because you might have missed an exam that you would have told you to get this imaging. Contrast urography. If you're thinking bladder, you can put contrast up stuff, and then you can up the catheter, and you can get an imaging that way and see that this contrast went where it doesn't belong, and that means there's a hole there, and you're bleeding. Extremity X-rays, TEE, bronchs, so you can scope wherever it's damaged. That is primary and secondary survey. This should be available for you somewhere. My 100-page trauma lecture would be too long for 1 hour, but it's out there. And then the other gals out there too. And then I've got these 3 books, pre-hospital, advanced trauma, and then TNS. Anybody ever wants that? And then at work, if you want to go over stuff, we'll get another trauma. We'll work on. We can pretend to be primary survey. Then we can do a thorough secondary survey, a repeat of what ER, because you're going to find what ER missed. Maybe the physician, maybe the surgeon, the trauma surgeon, maybe the nurse at the bedside. They got a lot of new people down there too. Not all of them have TNS anymore either. A lot of that is, so you need to be your plan C. You're the filter. You're catching either what they missed or what has changed, because what might not have been there, and now it is, but you got to catch it. You'd hate to go to surgery, do really good, at some sort of disastrous, awesome death. You knew they were going to die from this. Thank God somebody found it, but there was something else lurking the whole time. That's going to be your findings. So, cool. I like trauma. It's kind of fun. I'm a dork. Yes, that guy was so happy all the time. It's like, yeah, what's your secret to life? You're happy all the time. He's like, skulls and bats. I drop bowling balls on faces. I boil them up. Yeah. Other than that, I'm pretty good. Yeah.
Do you have the sign in?
The minute you have a head trouble, if you need a head problem, hypertension, you cannot be tolerated, hypoxia not be tolerated.
Yeah.
It's great to save all these things through, but the person's vegetable lifetime done, it doesn't matter.
Yeah.
The other is, in terms of disability, you're already examining the airway. What's one thing you can do to know that the patient is able to maintain the air? Ask them a question.
Talk to him.
If they can talk to you, obviously there's something, but don't wait till you to do your girl stuff because you're already at the head.
Yeah.
Because if they can't talk to you, there's a neural problem after that. That means it is an head trauma. That means any hypoxia, probably. It means any hypertension.
Yeah.
The last thing is, I would encourage all of you, if you have any interest, is read about the fast exams. There's plenty of secondary literature evaluation where what was done, what was done repeatedly in the ICU. Many times they found things, like resuscitate these patients, and you break clots.
There you go.
So the blood force stuff becomes more manageable. Find blood loss within the abdomen. If you can learn to do that yourself, you'll find the cardiac temperament before you understand paradoxes. You'll find a lot of those things that usually doesn't go there. And then lastly, I've seen a couple articles talking about 72 hours. It's kind of, when you look at any trauma patients, think of them in terms of 72 hours. So ours, we do a secondary assessment every shift or even every day for 72 hours. And then you'll find some. We had one very interesting case of Mr. Split Thumb. Had injury to his primary to his face.
Yeah.
That's where we found a dissected carotid.
Mhm.
When they told him it was injured just to his face, it doesn't happen. It does. And it was a traction.
Yeah.
We counted downstairs. But over time, we started noticing blood pressure issues, blood pressure spike. Realized the blood pressure stuff was over a fracture of his elbow.
Yeah.
That was probably why he was getting this every time he got pulled up. Then when he got off the ventilator and went to stand, he played knee pain, he had some plateau fracture. The arm was kind of a little obvious, the knee was less obvious. But again, I would wonder the regimen. The other's also 7 confined fractures too. So if you get out of that, you can see her out, you fracture, break it. You think there's a good fracture, you can fight it. So if you are interested, Wayland will teach you. I'll be happy to teach you and it's not. It's really not as difficult as you might think. It's very, very yes and no answers in very distinct places. And how to do that very completely, you can be surprised what you might.
Secondary brain injury is something we should look up. That's what he was when his first point of interest.
Well, also the same.
Yeah. Yep. So the hypotension, the hypoxia, things that increase intracranial pressure, pain, shivering, things that increase intracranial pressure. You can look them up on UpToDate. You can quickly Google it. You can just go to a website, go to the images. But anyway, look up those things to reduce intracranial pressure. That's so you can avoid secondary brain injury. You already had one, but the secondary is what causes the most damage. Gets you. So.
Well,
Yo.
pick a number.
9.
9. Correction. One, a $10 gift card for the coffee shop. Thanks for coming. Pick one other number between 1 and 23. Not mine.
17.
17.
Abby Elsie, she is on the line. Abby, I have a $10 BH Java gift card for you. I will put it in ICU or find your locker for you.
Oh, awesome. Thank you.
You're welcome. Thank you for coming, everybody.
Thank you. Thanks, Wayland.
Thank you.
How do I stop?